most of us, when we hear the word menopause, we associate it strictly with, hot flushes.
Right, or night sweats.
Yeah, exactly. Night sweats, or maybe bone density loss.
Yeah.
Like that is the cultural narrative we've all been handed for decades.
It really is.
But, okay, let's unpack this. What if I told you that one of the most debilitating, frustrating, and honestly sudden symptoms of midlife hormonal changes has nothing to do with your body temperature, and it actually has everything to do with the bottom of your feet?
Yeah, it's a huge blind spot.
Welcome to today's deep dive. Our mission today is to explore a really surprising phenomenon. We're looking at why so many active people, specifically women in midlife, suddenly develop this stubborn, agonizing foot and ankle pain, seemingly out of absolutely nowhere.
Just out of the blue.
Right. We're talking about conditions like Achilles tendinopathy and plantar fasciitis that just arrive one day, completely alter how you move, and then they just absolutely refuse to leave.
And for the listener joining us, if you are currently dreading those first few steps out of bed in the morning because of a sharp stabbing pain in your heel, we are speaking directly to you today.
We really are.
To get to the bottom of this, we are synthesizing a really comprehensive stack of sources.
Yeah.
We've got clinical guidelines from the NHS, insights from specialized podiatry and osteopathy clinics.
Yeah, and those groundbreaking papers from the journal Climacteric.
Exactly. Plus, recent clinical ultrasound studies that actually measure the precise thickness of these failing tissues in the foot.
It's a fascinating stack of research, honestly, because it completely flips the script on how we view joint pain. Like when this sudden heel or ankle pain hits, the immediate assumption is usually, well, I guess I'm just getting older.
Right, the wear and tear excuse.
Yeah, or I must have walked too much in those flat shoes. It just gets written off so easily.
But the sources show us a completely different reality. I mean, this isn't simply mechanical wear and tear. What we're looking at is a profound systemic cellular shift in how the human body maintains and repairs its connective tissue.
Which is wild to think about.
It is. And before we can even begin to understand how the Achilles tendon or the arch of the foot physically breaks down, we have to look at the invisible architect that built those tissues.
And keeps them strong.
Exactly. And that architect is estrogen.
We really need to rebrand estrogen, don't we?
Oh, absolutely.
Because we're taught to think of it exclusively as a reproductive hormone, tied to the menstrual cycle and pregnancy.
Right.
But the clinical data shows it is actually a master regulator of collagen turnover.
Yes.
And collagen is the primary structural protein in your body. It's the literal building block that gives your tendons and your ligaments their incredible strength and, crucially, their elasticity.
And that's the key right there, the elasticity. Because connective tissues throughout your entire body are packed with estrogen receptors.
They're just everywhere.
Yeah, they're constantly listening for that specific hormonal signal. But during perimenopause and menopause, when estrogen levels begin to fluctuate and eventually plummet, those receptors essentially go quiet.
Wow.
And without that continuous chemical signal, the cellular factories that produce and maintain collagen, they just start to slow down their production lines.
The analogy that really helped me visualize this, it's like a standard kitchen sponge.
Oh, that's a good one.
Right. When that sponge is fully saturated with water, it is incredibly resilient. You can twist it, you can pull it, you can wring it out, and the second you let go, it just bounces right back to its original shape.
Because that hydration gives it flexibility.
Exactly. Estrogen acts like the water in the sponge for your tendons.
That visual captures the mechanical reality perfectly. Because, think about it, if you leave that exact same sponge on the counter for 3 days until it is bone dry, its physical properties change entirely.
It's hard as a rock.
Right. You try to bend it, and it doesn't bend. It cracks. It tears under the exact same pressure that it easily handled just a few days prior. Ugh, that makes so much sense.
So as estrogen drops, the tissues effectively dry out, leading to increased tendon stiffness and a significantly higher baseline of systemic inflammation.
And the medical community is seeing this so frequently now, right? They're starting to group these symptoms into a newly recognized condition.
Yeah, the musculoskeletal syndrome of menopause.
Right, the musculoskeletal syndrome of menopause. It's this massive cluster of issues, sudden joint pain, tendon irritation, frozen shoulder, and they're all masquerading as isolated injuries.
But they're all fundamentally triggered by this single hormonal shift.
It's just incredible. And what's fascinating here is that the structural drying out of the sponge isn't the only biological hurdle. We also have to look at the brain's chemical balancing act.
Right, the cortisol connection.
Exactly. Estrogen naturally acts as a buffer or like a regulator for cortisol, which is our primary stress hormone. Think of it like a chemical seesaw. When estrogen levels are high and stable, they keep cortisol levels in check. But when estrogen drops during menopause, that buffer is completely removed and cortisol levels can rise unchecked.
And higher cortisol doesn't just make you feel stressed or anxious, right? It physically changes how your body processes pain.
It creates a hypersensitized state. Elevated cortisol makes your central nervous system much more sensitive to pain signals.
Oh, wow.
So not only are your tissues physically weaker and more prone to microscopic damage from everyday walking, but your brain's alarm system is also turned up to maximum volume.
That is wow. So you are feeling the tiny micro tears much more acutely than you would have a decade earlier.
Exactly. Your pain threshold biologically plummets at the exact moment your tissues become more vulnerable.
It honestly feels like a cruel biological joke.
It really does.
The structure gets weaker and the alarm gets louder, which perfectly sets up what happens to the Achilles tendon.
Let's talk about the Achilles.
Yeah, because if we know the sponge is drying out and losing its elasticity, what happens to the largest, thickest tendon in the human body when it loses its literal bounce?
Well, the Achilles is a marvel of biological engineering. It functions exactly like a heavy-duty biological spring.
Right.
Every single time you take a step or run or jump, it absorbs massive amounts of kinetic energy, stores it momentarily, and then releases it to propel your entire body weight forward.
But the sources are very clear. The tendinopathy in the Achilles doesn't just happen because you took one weird step off a curb.
No, not at all.
It isn't a snapped rubber band. It is this slow, insidious process that develops over weeks or months through repeated microtrauma.
Because every loading cycle, every single step you take creates a tiny amount of microscopic damage at the cellular level.
Which is normal, right?
Totally normal. In a younger or highly estrogen-supported environment, your body easily repairs this microscopic damage while you sleep. It's a continuous, healthy cycle of breakdown and repair. But because of the estrogen drop, the cellular factories simply can no longer keep up. The daily damage suddenly outpaces the overnight repair.
And here is a crucial detail from the clinical biopsies of these chronically painful Achilles tendons. They show that what is happening is not what we traditionally call tendinitis.
Right, the language here matters.
It does, because the suffix itis implies inflammation. But these biopsies show minimal inflammatory cells. Instead, the diagnosis is tendinosis.
Tendinosis, which refers to actual collagen degeneration. The tissue itself is degrading.
Wow.
The individual collagen fibers, which should be arranged in these neat parallel lines, kind of like the cables on a suspension bridge, they become physically disorganized and tangled.
Like a messy ball of yarn.
Exactly. And this breakdown happens most frequently in a very specific area of the Achilles, about 2 to 6 centimeters above the heel bone.
Because that particular spot naturally has a very limited blood supply, right?
Yes, it's considered a watershed zone.
Yeah.
Less blood flow means fewer repair cells, and fewer nutrients are making it to the site of the damage to begin with.
Makes sense.
So when you combine that natural anatomical vulnerability with a sudden drop in collagen production due to menopause, that specific zone of the tendon becomes incredibly fragile.
Okay, wait a second. I want to push back on how we usually treat this kind of pain.
Go for it.
If clinical biopsies are proving that there are barely any inflammatory cells present, and the collagen fibers are actually physically tangled and disorganized, doesn't that mean that popping over-the-counter anti-inflammatories and completely resting on the couch is addressing the entirely wrong problem?
That is a vital realization. Treating tendinosis with pure rest and anti-inflammatories is a massive flaw in how this has historically been managed.
Because there's no inflammation to fight.
Exactly. Rest alone will not reorganize disorganized collagen fibers. Going back to your analogy, if you have a tangled ball of yarn, simply putting it in a drawer and ignoring it won't untangle it.
Right.
It just sits there, remaining tangled and weak.
You are literally just waiting around with a weak tendon.
Yeah. The tendon desperately needs the right mechanical stimulus to heal. Complete immobilization actually makes the tendon weaker because the cells aren't receiving any instructions on how to rebuild.
Unbelievable.
We will get into exactly what kind of movement provides those instructions in a moment, but first, we have to follow this problem further down the leg.
Right, because the loss of elasticity and this disorganized collagen doesn't just stay isolated in the back of the ankle. It travels down the kinetic chain.
It does.
And for the listener, the kinetic chain is just the continuous sequence of load-bearing biology. It's how the movement of your knee affects your ankle, which affects your heel, which ripples right down into the arch of your foot.
Which brings us to the plantar fascia.
Yes, the plantar fascia.
The plantar fascia is a thick, fibrous band of connective tissue running along the bottom of your foot. It connects your heel bone to your toes and acts exactly like a bowstring to support the arch of your foot.
And the sources describe how menopause creates a triple threat to this vital bowstring. We need to look at each of these threats because they compound on each other.
They really do.
First, as we just discussed with the Achilles, the fascia itself becomes less pliable due to the systemic loss of estrogen-driven collagen.
Right. The sponge dries out, making the tissue stiff and brittle.
Exactly. Then the second threat is global ligament laxity.
Yes. Declining estrogen doesn't just affect tendons, it affects the ligaments holding the actual bones of your foot together.
Oh, wow.
Those ligaments become slightly looser, and as a result, the foot physically spreads out. It gets wider, and the arch naturally begins to flatten under your body weight.
Okay, here's where it gets really interesting. Think of your foot like a complex suspension bridge.
Okay.
The ligaments are the tension cables up top, keeping the bridge aligned and holding the structure together. The plantar fascia is the main support beam running underneath. If the tension cables up top get slack and the bridge starts to sag, all of that displaced weight has to go somewhere.
And that weight is immediately transferred to the support beam underneath. The plantar fascia is suddenly forced to bear an impossible amount of tension just to keep the foot from collapsing entirely.
It is being pulled tighter and tighter every time you stand up.
Exactly.
And just add insult to injury, we have the third part of the triple threat, the protective fat pad under your heel.
Right.
This pad naturally thins out with age and hormonal changes. So exactly where this hyper-stressed bowstring attaches to the heel bone, you have significantly less cushioning to absorb the impact of walking.
It's the perfect storm. And this triple threat leads to a fascinating and, frankly, painful diagnostic finding.
Yeah.
A recent clinical ultrasound study looked closely at women suffering from plantar fasciopathy. The imaging revealed that as the plantar fascia breaks down under this impossible load, it actually artificially thickens.
It gets thicker. You would think it would get thinner as it breaks down.
You would think so, but it is the body's emergency response system. Because the normal collagen production is impaired, the body frantically throws down disorganized scar tissue to try and reinforce the failing bridge.
Oh, I see.
It is building haphazard biological scaffolding just to keep the tissue from tearing completely.
Wow.
And the clinical study confirmed a direct correlation. When the fascia thickness exceeds 0.4 centimeters, the intensity of the pain the patient feels directly matches that thickness.
So the thicker the disorganized scar tissue, the worse the pain,
Precise.
which perfectly explains the hallmark symptom of plantar fasciitis. Anyone who has had this knows the absolute breathtaking agony of those very first steps out of bed in the morning.
Yeah, the morning pain. And it makes perfect mechanical sense when you understand the tissue behavior.
How so?
Well, while you sleep, that thick, disorganized, dehydrated scar tissue tightens up. It contracts into a shortened position overnight. So when you wake up and put your foot on the floor, you are suddenly forcing your entire body weight onto a stiff, inflexible band before it has had any chance to warm up, stretch, or hydrate.
Ouch.
You are essentially ripping the microtears back open every single morning.
That is horrifying. But understanding the structural and hormonal mechanics is incredibly empowering too,
It is.
because it validates that we aren't just imagining this pain. It is a real physical breakdown.
Yeah.
But the big question is, how do we actually rewire the architecture?
Right.
Like, if complete rest doesn't work, how do we fix disorganized collagen and unsupported arches?
It requires a highly strategic, active approach to recovery. First and foremost is targeted physical therapy. The absolute gold standard for tendon and fascia recovery is eccentric loading exercises.
Okay, the sources keep using the term eccentric loading, but to a layman like me, that just sounds like, lifting weights in a gym. Why is the word eccentric so crucial here?
Good question. Eccentric refers specifically to the lengthening phase of a muscle contraction. Right. Imagine doing a calf raise on the edge of a stair. Pushing up onto your toes is the concentric phase. That's the shortening.
Yeah.
Slowly lowering your heel drop back down below the level of the stair is the eccentric phase. Eccentric exercises safely lengthen the muscle and the tendon while they are actively bearing weight and under tension.
So you are stretching it and strengthening it at the exact same time.
Precisely. That specific mechanical tension provides the cellular signal the body desperately needs. It tells the cellular factories to break down the disorganized, tangled scar tissue and lay down proper, straight, linear collagen fibers.
It untangles the yarn.
It untangles the yarn.
But its sources explicitly warn against aggressive passive stretching,
Sure.
like standing, facing a wall, planting your foot back, and just aggressively pushing your heel into the floor and holding it there.
Yes, passive stretching just yanks indiscriminately on the tissue. Without the active load of the muscle working, you are just pulling the disorganized fibers apart and creating more micro tears.
Oh, that sounds awful.
It is counterproductive and often delays healing. You need the muscle active to remodel the tendon.
That makes perfect sense for the mechanical side.
Fair.
But if eccentric loading fixes the tangled yarn, what fixes the dry sponge?
Ah.
If the root cause of the collagen breakdown is a systemic lack of estrogen, doesn't it make logical sense to explore putting the estrogen back? What about hormone replacement therapy?
The clinical guidelines certainly support exploring HRT as part of the puzzle. Research shows HRT can significantly improve tendon structure, reduce overall tissue stiffness, and limit the loss of muscle and bone mass.
Wow.
And it is worth noting that there has been a massive paradigm shift in how HRT is viewed by the medical establishment recently.
Right, the FDA fundamentally changed their stance on this, didn't they?
They did. The FDA recently removed the notorious black box warnings for cardiovascular disease and dementia for women starting HRT within 10 years of the onset of menopause.
That is huge.
It's massive. For decades, those warnings scared countless women away from treatment. The removal of that warning is a huge acknowledgement by the medical community of estrogen's vital protective role in overall health.
Which absolutely includes maintaining musculoskeletal integrity.
Exactly. Obviously, HRT is a highly personal medical decision with its own individual risk profile, but the consensus is rapidly shifting to recognize its protective benefits for joint and tendon health.
So beyond physical therapy and hormones, the podiatry sources emphasize critical lifestyle modifications too.
Yeah, they do.
Like maintaining a healthy weight is pure physics. Less load on a compromised suspension bridge means less strain on the plantar fascia.
Absolutely.
Consistent footwear is also a major factor. Wearing shoes with proper heel height and sturdy arch support temporarily does the job your lax ligaments are currently struggling to do. It basically gives the tissues a break so they can heal.
And for particularly stubborn cases, the sources point to advanced interventions like shockwave therapy.
Oh, right.
This involves using acoustic waves directed at the injured tissue. The acoustic waves create micro-trauma that stimulates massive blood flow to that stubborn watershed zone we talked about, and it triggers what is called pro-collagen synthesis.
Pro-collagen synthesis meaning it jumpstarts the manufacturing process.
Exactly. It essentially wakes up those dormant cellular factories we talked about earlier and forces them to manufacture fresh, highly organized structural proteins to rebuild the tissue from the inside out.
But it is important to set expectations here. None of this is a quick fix.
No, absolutely not. We are talking about literal cellular remodeling. The biological timeline for tendons and fascia to properly reorganize, untangle, and heal is 3 to 9 months of consistent work.
3 to 9 months.
It requires immense patience.
So what does this all mean for the listener who is sitting in their doctor's office right now, frustrated out of their mind?
Yeah.
Because so many women are just being told to take some painkillers, buy softer shoes, and stay off it. How should they advocate for themselves?
Well, if we connect this to the bigger picture of care, treating the foot in total isolation without looking at the hormonal environment is a massive disservice.
Totally.
You need to advocate for a holistic recovery plan. Tell your doctor you understand this is likely tendinosis, not an inflammatory tendinitis.
Yes.
Ask for a referral to a physical therapist who specifically understands progressive eccentric loading for midlife women. And if it is appropriate for your medical history, initiate a conversation with your gynecologist or endocrinologist about your hormonal environment.
Because treating the mechanical pain without addressing the underlying hormonal deficit or the need for active tissue remodeling will just leave you trapped in a chronic cycle of injury.
You have to treat the whole machine, not just the squeaky wheel.
I love that. To wrap up our deep dive today, the major aha moment here is that midlife foot and ankle pain isn't some mysterious failing of your body.
No, it's not.
It isn't just a punishment for walking too much or getting older. It is a highly specific mechanical response to a profound biological shift in your hormones.
Hmm.
Estrogen regulates the water in the sponge.
Right.
When the sponge dries out, the Achilles loses its spring, and the plantar fascia bows under the weight of the loosened foot.
Mm.
But knowing the mechanics means you can actually manage it with targeted loading, patience, and the right medical support.
It is entirely about giving the body the right signals to rebuild itself. And, I'd like to leave you with a final thought to consider, something that builds on everything we've explored today about the estrogen-collagen connection.
Oh, what's that?
If estrogen levels so directly dictate the elasticity and vulnerability of our tendons in midlife, what does this mean for younger, premenopausal women?
Oh, that is a fascinating pivot.
Think about the mechanics of a normal menstrual cycle. A premenopausal woman experiences massive, rapid spikes and sharp crashes of estrogen every single month.
Right, they cycle.
That means her connective tissues are constantly shifting from highly elastic and hydrated to suddenly stiff and vulnerable within a matter of days.
Wow, I never thought of that.
Could tracking ovulation, knowing exactly when your tendons are most physiologically vulnerable due to these monthly hormonal crashes, be the secret to predicting and preventing catastrophic sports injuries, like an ACL tear or a blown Achilles, long before menopause even begins?
Wow. So the medical system might still be struggling to diagnose tendon pain correctly, but a simple calendar tracking our hormones might actually give us the clearest picture of our joint health we've ever had.
It's very possible.
We'll leave you to think on that. Thanks for joining us on this deep dive.